few drugs where distribution plays a role with third space. So
Exactly.
third space.
Yeah. And Marcus, do you want to comment on this third space? What do you mean by that?
Well, methotrexate is, as I said, one of the few, I think, drugs, anti-cancer drugs, that we have to be very careful because it distributes into third space. So that distribution is important. And if patients have pleural effusion or ascites, they can have very severe toxicity from a particular high dose methotrexate because it goes into the third space and then redistributes over many days back to the blood. And this prolonged exposure um, makes the patients then at high risk for severe toxicity. And that's one of the few examples I know where the distribution is really important.
And so in case we have a patient with ascites of pleural effusion, which is your recommendation? To drain?
Yeah, you should drain if ever possible, yeah.
To drain before the administration? Yeah. Okay. Okay, and also in this case, also the albumin value is of relevance, so you can have a higher distribution in the, because usually these patients have also a low albumin value because they have the ascites and there's a hypoproteinemia. So they are really critical patients or patients which are at high risk of toxicity.
Well, the case of free drug is something that has at times very controversially been discussed in the literature. And yes, it seems, of course, free drug is the active drug. But usually this placement results in a new balance, because then more drug is eliminated,
right,
and vice versa. So it's unclear. Probably it's only when it gets disbalanced that for a certain time there is more or less free drug, and usually gets in a new steady state.
Okay.
But I think there are examples where this can count, in particular patients that are very cachectic, have a low albumin level.
Yeah. So thank you very much. Well, the other point I wanted to mention, because I think that this is important also from the practical point of view, and mostly for in situation where we need a rapid effect. I refer to some antalgic treatment, for example. So the point is that which is the time needed to reach the effect according to the different route of administration. And so it's important to remember that when you have the oral administration, you have a longer time, which could be quite variable, while when you have an intravenous administration or a sublingual administration, the effect can be achieved more rapidly. The other point is that more or less we have an idea when the peak concentration is achieved. And therefore, if the patient has some episodes of nausea or mostly vomiting after the administration of the drug, which can hypothesize that the drug has been absorbed or not. In general, my recommendation, but I don't know, Marcus, what you think, is that when we have a for example, twice day administration of the drug, and we know that the patient vomited 1 hour after the first administration, usually I don't say take another pill now, because I know that there will be the administration in the evening. And if the absorption is variable, the risk is that you have an accumulation of the drug, which might be also toxic. So in general, unless you have a very rapid absorption, but you have some time to reach the peak concentration, I say to abstain to take another dose of the drug, but to wait until the night or the subsequent dose. Now, the point is that, well, I want to remind you that you can ask questions and comments at any time, and Marcus and myself will be glad to discuss or to answer to your questions. Now, let's go to some more complicated parameters. We don't have to know the formula. I think it's important to understand the concept. And the first concept I wanted to discuss with you is the volume of distribution, which is an important parameter. And the definition is that theoretical volume necessary to contain the total amount of drug which is given at the same concentration that's observed in plasma. So we can imagine that we have a big box and that the drug is distributed homogeneously within this box and is distributed in tissues rather than in plasma. And clearly the volume of distribution depends on the properties, the physicochemical properties, for example, the lipid solubility of a compound. It depends on the plasma protein binding, but also it's increased in case of renal failure because the drug stays around for a longer time, and it's also increased in case of liver failure. And the higher volume of distribution overall means that the drug stays around for a longer period, so there could be a higher risk of toxicity. The example of the third space Marcus mentioned before. Each time we have a delayed excretion, there's a higher risk of toxicity because that's related to the exposure of the drug. Now, this is something I thought it was important for you to know. How or which could be one potential use of the volume of distribution. So when we know which is the volume of distribution, how much the drug goes into tissues for a particular compound, we can calculate the loading dose, and the loading dose is the dose which is given to achieve rapidly a constant concentration in plasma, the steady state concentration, because for some drug, for example, for cardiovascular agents, it's important to achieve quickly the therapeutic concentration, but also how we can maintain a therapeutic dose. And the maintenance dose, so the dose which is to be given repeatedly to reach a steady state concentration, can be calculated on the volume of distribution. Perhaps this is something we can discuss later on, but keep in mind that the maintenance dose are relevant also for the oral drugs which are administered chronically. And this is important for the new drugs, TKI inhibitors and so on. And then perhaps Marcus would like to comment on the need to sample sometimes the trough level to see whether we can keep a therapeutic concentration in the plasma. The other important concept is the half-life. The definition of the half-life is the period of time required for a plasma concentration of a drug to be reduced by 50%. And the half-life depends on how quickly the drug is eliminated from the plasma. So this is a typical representation of the plasma profile, plasmatic disappearance curve, when you have the concentration and the time. And the point is that in each plasmatic profile you have, and you can distinguish in the curve of elimination, two phases. The first one, which is quicker, which corresponds to the distribution phase. During this period, the drug goes from the vascular compartment into tissue. So you can see that the slope of the curve is steeper. And then there's an elimination phase, and this is hours or could be another unit of time. But as you can see, the slope is less steep. And this corresponds to the elimination from the body. And clearly, if we have a reduced excretion, we can have a delayed elimination, and the drug stay around longer. So please ask whatever you want to clarify or you want to know in your question. I'm going back to the steady state concentration. For example, let's refer again to the methotrexate high dose, or could refer to the ERA-C. We know which is the cytotoxic concentration we have to achieve, more or less. That's quite clear with methotrexate and also with high dose ERA-C. So the point is that which is the steady state concentration we want to get for other drugs, and how we can achieve it. So the definition is the amount of drug administered is equal to the amount of drug eliminated within one dosing interval, and we have a plateau or a constant serum drug level. What is important to remember that the steady state concentration can be changed by changing the dose and the dosing interval. And the longer is the half-life of a drug, and the longer is the time to reach a steady state concentration. And the time to reach it usually corresponds to 4 or 5 times the half-life. So to give you an example, in the first studies which were done with olaparib, which is a chronically administered drug, there was the discussion about the optimal dose and the optimal schedule of administration. And one of the criteria was to test whether the potentially cytotoxic concentration, or more than cytotoxic, the active dose at the receptor level, could be achieved in plasma, and when. And there were studies with the repeated pharmacokinetic sampling with the definition of trough levels. And the first sampling was done 1 week after the administration, after 1 week of administration, because it was calculated according to the half-life that it was needed at least 1 week of treatment to reach, with some chance of reaching, the steady state concentration of the drug. And then clearly should be repeated weekly to see whether the concentration can be maintained. And that's important for compounds and the new compounds we were discussing before with Marcus, when we don't have the criteria of the toxicity, which was used in the past for chemotherapeutic agents, to say, are we getting an active dose or not? Because with the new compound, the TKA and small molecule inhibitors, we don't have the parameter of the hematological toxicity. So we should have other parameters which help us in deciding which is the optimal dose to be used in the clinics. And this is the concept of the loading dose. It's just a representation. So if you look at the yellow line, this is the time which could be needed without the bolus. So we need this period of time to get the target therapeutic concentration. If we have a loading dose, in this way, with the red line, we can go a bit higher, but then it goes down quickly, and then we can go more rapidly to a concentration which is over the therapeutic targeted one. Now, this is another concept, because very often when we listen to some presentation and we see some data, there's the statement where there's a linear pharmacokinetics, which is always very nice. To have a linear pharmacokinetics is one of the desired criteria for selecting a compound, because the rate of elimination is proportional to the amount of drug present, and when we have an increase of the dose, we have a proportional increase in the plasma drug levels. But this is not the case for all the drugs. we can have nonlinear pharmacokinetics. And at this point, we can have problem. So the point is that we have an increase of the dose, we have an increase of the concentration up to a certain dose, but after that, the increase of the dose is not linear. And this might be related to the fact that there's a saturation in the elimination system. At this point, we have a curve which is not linear any longer, and we can have an accumulation, which might be risky, or we can have a disproportionate increase. And this is the reason why, for some drugs, minor changes in the dosage could have, for example, significant changes in the toxicity. That might be related to some nonlinearity, and therefore it's important in the early stage of development to have a pharmacokinetic study concomitant to the clinical study, because that might be useful to understand some unexpected toxic effect, and that's also useful to define the optimal schedule for the subsequent clinical development. Marcus, if there are points you want to comment, please interrupt me.
Yeah, we don't have yet some questions from the attendees, but please feel free. Linear and non-linear PK, we discuss a lot if we do phase 1 trials, and everybody got nervous if there is non-linearity, although if the therapeutic window is large, usually non-linearity is not necessarily a big problem.
Okay. So let us also know if there are concepts which are unclear or which are a bit complicated, or if you need more time so that we can take more time and go more in details, or we can go back with some practical example. Because the idea of the session of today is to have some hints of how to use this knowledge for a better management of the drugs. Now, this is a representation of what is going on in the body with the drugs. So we cover the point of the absorption, and we cover the point of the distribution, and then now we are going to see the first pass effect. So what happens in terms of metabolism, and this is mostly related to the liver effect. So the point is that the administration could be oral, and we discussed already the absorption from the gut. The administration could be intravenous, and we discussed already the free drug, the plasma protein, and the passage into the tissues, the tissue reservoir, the third space effect, the effect on the site of action. But let's see what happens in terms of metabolism. So the invitation to ask whatever you need and you want. And then this is the first pass effect. So the point is that there's a great decrease of the concentration before the drug reaches the systemic circulation. For example, for a drug which is administered orally from the gut, the drug goes into the liver through the hepatic portal system, and then there's a transformation of the drug. And then the drug can go to the systemic circulation, but that means that the concentration in the systemic circulation could be definitely lower because of the effect of the liver. And for some drugs, the oral administration is not feasible at all because there's a too extensive transformation. And the first pass effect is affected by the enzymes which are in the gut, in the wall, and the bacterial enzyme, and mostly by the liver enzyme. And this is a cartoon with the first pass effect. So this is what we have observed and discussed so far. The hepatic portal system go to the liver, and then from the liver in the systemic circulation and go in the body. And it's different according to the different routes of administration. And for example, some drugs are not suitable for the oral administration because of a very extensive first-pass effect and should be given through other routes. However, there's also the enterohepatic circle, which means that through the liver metabolism, the drug is in the bile, and then there's an intestinal reabsorption and go back again to the gut. And in this case, there could be a later increase of the concentration in the blood. So it's known for some drugs that there's an enterohepatic circle, and this could be responsible for some delayed toxicity. It's just important to know. Usually is specified which are the drugs with the enterohepatic circulation. And then the important point of the extraction. What is the extraction? We talk of extraction for all the excretory organ, and is the rate of plasma drug removal by an organ of elimination, and divided by the rate at which the drug is presented to this organ. So how much drug is eliminated by the organ through a period of time, and this is the extraction rate. So the drug arrived to the organ, there's the extraction, and then the blood leaves and go into the systemic circulation. What we should know about that, we have an hepatic extraction, and this is a measure of the efficiency of the liver in eliminating the drug from the systemic circulation over a single pass. And this is affected by the blood flow, by the protein binding, but also by the intrinsic ability of the liver. And the extraction and the clearance depends very much from the blood flow, and if the drug has a high hepatic extraction, whatever is the blood flow, the liver is able to remove all the drug. So the blood flow is not so relevant. But the point is that if the liver has a low hepatic extraction, which is related to the intrinsic ability, a higher dose could result in a higher concentration in plasma and therefore a higher toxicity. And clearly there are diseases which could affect the extraction from the liver, the cirrhosis situation where we have a change of the blood flow, or a situation of the hepatitis, or for example, some situation on concomitant treatments or overdosing of some drugs. The hepatic extraction is one of the most important parameters, and we should know for the drug we are using, which is the hepatic extraction, because, for example, for compounds like anthracyclines, the liver function is extremely important, and those should be adapted to the liver function. While for some other drugs the liver function is not so relevant, and the dose could be given, and the drug could be given at almost full doses in spite of an impairment of the liver function. I don't know, Marcus, if you want to comment on that, or perhaps we can comment when we go further in the liver metabolism. But there are general concepts of the use.
There is no good guidelines on how to dose anti-cancer drugs in patients with liver dysfunction. There is one ESMO publication that can be recommended. I participated there with Jan-Hendrik Böhmer, but there is not a lot of good data.
Yeah. The point is that one of the questions is that which are the good parameters of liver function to look at to decide whether we should reduce the dose or not. I think it depends on the metabolism, because the point is that very often we have alteration of the transaminase, but the liver function is good anyway. That's an acute situation. But if you have a situation, for example, of hepatic cholestasis, where you're not able to excrete out the drug, that could be a situation which is potentially more toxic. So I think in general it's really important to have the bilirubin value and the fractionated alk phos. Disregard other enzymes like gamma GT, LDH, which are very often altered by the other concomitant drugs or concomitant disease. And then the point is that there are some rules, but really the point is that there are not clear criteria. That's something which is to be applied with some cautiousness. Perhaps it could be useful to start with a lower dose and then increase later on the dose according to the tolerability. Then there are other situations where the liver function is important for the metabolism. For example, there are drugs which are activated in the liver, and in case of liver dysfunction, the drugs cannot be activated to active species. So it's useless to administer for an oral or IV administration. The typical example is cyclophosphamide because it's activated in the liver. So if you give cyclophosphamide in case of liver dysfunction, it's not toxic, but it's also not active. So it's better to go to some other compound. So these are some tricks, but it's important to know. Then these are the points which are the factors affecting metabolism, and this is something which is the knowledge is improved a lot in the last time, and perhaps Marcus you want to comment on that, the genetic factors and the pharmacogenetics. And the pharmacogenetics is the study of the inherited genetic differences in drug metabolism, which can affect the drug response because they can affect they are related to change in the gene expression and the production of protein. And pharmacogenomics, and very often the two words are used in an interchangeable way, is the study of the role of all the genome in the drug response. Other important factors are concomitant drugs like enzyme inducers and inhibitors, and Marcus is really an expert on that. And the other point is the age. There are some change in the metabolism in elderly as compared to younger person. As well, we should remember that in newborn the system is not matured up to 6 months, while also situation of liver disease could affect the metabolism. So it's really important to have a general picture, to look at the exam, to have a careful collection of the clinical history to decide whether the extraction and the metabolism is good or is adequate for that particular treatment.
Christiana, maybe it's important to tell our young colleagues that if you're talking about pharmacogenetics, it's not the somatic mutations in the tumor, but it's germline. And there was a time where we thought that we could explain a lot of the inter-individual variability in drug response with pharmacogenetics. This has not come true, but there are some examples, for example, mercaptopurine and fluoropyrimidines and irinotecan, where pharmacogenetics is important.
Yeah, I fully agree, and this is an important concept because I have really practical clinical implications. Mercaptopurine for children, it's really because it's given orally and the metabolism could be really different. As well, DPD, the example of the unexpected severe toxicity after 5-FU and also capecitabine, and the other point, irinotecan, and that's really a nice example, the occurrence of severe unexpected diarrhea in patients with the alteration of the metabolism, which is related to some pharmacogenetic differences. And the other point is that perhaps there are pharmacogenetic differences related to race, and this is one of the reasons today to get a new registered compound. It's important to have studies done not only in Europe, Caucasian population, but also in the Asian populations, because there are relevant differences. For example, pazopanib, the metabolism of pazopanib is different in the Asian population as compared to Caucasian. So this is really an important point. It can explain mostly toxicity and perhaps sometimes the anti-tumor activity. Right. So I think the key is the cytochrome P450 enzyme family, which is located in the hepatocytes. And Marcus, perhaps you want to say 2 words or why this system is so important and very often is mentioned, but nobody really knows how much is relevant and how much attention we should pay to it.
Yeah. Right. So the anti-cancer drugs that are substrate of this enzyme system are quite prone to drug-drug interactions. I think that's one reason that the cytochrome system is quite important. The other thing, of course, is patients with drug dysfunction, they will have a lower function also of these enzymes.
Yeah. Now, the point is that when we talk of enzymatic changes, we can distinguish between enzymatic inducers and enzymatic inhibitors. So it's a type of drug that increases the metabolic activity of an enzyme that metabolizes a drug. So if you give together concomitantly the 2 drugs, there's an increase of the metabolism, and if the metabolic pathway is a detoxifying pathway, there could be an increase of the drug elimination, and it would be important to give higher doses to get a similar effect. And this could be related to smoke, to alcohol, but could be given to some concomitant drugs. The typical example of the anti-epileptic drugs, where there could be an induction of the metabolism, and therefore the dose are not sufficient anymore and could be increased. There were studies in the past with a combination of irinotecan and anti-epileptic drugs where the drug of where the level of irinotecan were lower because there was an induction of the metabolism. And the other situation is the enzymatic inhibitors. And in this case, when there's an inhibition of the metabolic activity, the elimination of the chemotherapeutic agents is decreased, and therefore we should decrease the dose as well. I have a question, which is a very common question. A patient comes and should start a treatment, and the patient is taking a drug which is known to be an enzymatic inducer. So how much time of washing should I need before starting the treatment? For example, patients are taking sleeping pills and they say, well, I want to take my sleeping pills. How many days without the sleeping pills I should wait before starting the treatment? Marcus, you have a recommendation on that?
Yeah, so the typical enzyme induction goes via a certain system and receptor, which is called ERP, and those effects usually would take like 2 to 3 days.
Okay. So the recommendation would be to have 2 or 3 days of washing before starting the treatment. And also steroids could have some enzymatic induction in some way, the corticosteroids which are given. So it would be also the same to have 2 or 3 days of washing. Okay. And then the point is that once the drug is given, 24 hours after, we can start again with the concomitant treatment. And this could be clearly a problem for chronic administration, and we should try to change to another drug which is known not to be an inducer. But very often in the compendium it's reported the list of the compounds which are inducers or inhibitors, and I think in case there are doubts we could ask the drug company of the pharmacist to check whether the 2 drugs can be given together or better not. Now, the point of the renal elimination. This is the other important point. So liver is important for metabolism, kidney is important for elimination, and in case we have a decreased renal function, there's a decrease of the excretion for drugs for which the renal excretion is the most important way of detoxification. So the renal elimination depends on many factors, which is the renal blood flow, the glomerular filtration rate, which is also related to the unbound fraction, and the glomerular filtration rate eventually is best represented by the creatinine clearance, calculated according to the Cochrane formula or another formula. It hasn't been proven that the 24-hour urinary collection is better than the creatinine clearance calculated on the creatinine in plasma. The urine flow and the pH, and this is, as you remember, very important for the, again, methotrexate, the tubular reabsorption and the secretion. So these are the three processes which are relevant, which piled up to give the renal excretion: the glomerular filtration rate, the secretion, and the reabsorption. So for the drug, we should know more or less which are the steps which are relevant for that particular drug. For example, for carboplatin, we know that the most important one is the glomerular filtration rate. For methotrexate, we know that really the active secretion and the reabsorption are also important steps, and then therefore we should pay attention to the pH. And then again, the plasma protein bindings, which refers to what Marcus mentioned before. When you have a higher unbound fraction, you have a higher amount of drugs which pass through the kidney at the level of the glomerular filtration rate, so that you can lose a higher amount of drug. And this is the renal clearance. The renal clearance is the volume of the plasma which is cleared of the drug by the kidney per unit of time. And total clearance is done by the sum of the clearance of the different organs which are involved in the excretion, which is the renal clearance, the hepatic clearance, and other, perhaps the respiratory clearance. And this is important to have an idea of the capacity of the body to get rid of the drug. So, in which situation the renal function is altered and when we should pay attention? In the elderly. In the elderly, the creatinine and the creatinine clearance are not so representative of the renal function because the kidney doesn't function properly any longer. So the creatinine clearance is lower anyway, and the creatinine could be also lower, but this could be related also to the intake. So it's with elderly, it's always better to stay on a cautious side when we are dealing with drugs with the main renal excretion and we have to start a new treatment. And also in newborn, the renal function is lower. And therefore, when we should pay attention with drugs with the main renal excretion, if the kidney doesn't function properly, in drugs with a low therapeutic index, because it could be easier to have to go to a toxic dose instead of a therapeutic one because there's an accumulation. And also when they are given concomitantly to drugs which could alter the renal function. And the typical example is when we give concomitantly non-steroidal anti-inflammatory drugs, because they could decrease the renal function. And if the kidney has already decreased activity, it could be easier to have an accumulation. And this is the typical situation of carboplatin, cisplatin, all the drugs with a kidney excretion. Avoid for the period of time Marcus mentioned before, to give drugs which are excreted through the kidney, but also which are potentially nephrotoxic. And the typical situation is ifosfamide and the combination with cisplatin, or ifosfamide in patients with abnormal kidney function, and so on. There are rules how to adapt the dose, but the general recommendation is to avoid, if possible, to give this type of drug, unless you are dealing with a curable disease and a very sensitive disease, very sensible to this drug, like the situation of testicular cancer and so on, where we should try to adapt the dose and pay attention to try to get always a rescue to the potential toxicity. Marcus, do you want to add something on that?
Yeah, I think the non-steroidal antirheumatic drugs are something we have to be very careful. There are a lot of chemotherapeutics eliminated by the kidney, and we have regularly severe toxicity in those cases. So try to avoid and maybe use paracetamol or metamizole instead of NSAIDs.
Yeah. And my recommendation would be to check always at least creatinine before starting a treatment. Even though you have a creatinine which was done 1 week before, it's a mildly higher, it's better to recheck. Because, for example, in elderly, there could be changes which then could significantly affect the pharmacokinetics. Now, that's always the invitation to have questions, and then let's go to the last part, and this is a fascinating part where Marcus is really an expert, the pharmacokinetic model. So we have seen so far which are the parameters, but then the point is that we can simulate now which is the behavior of a drug within the body, and try to calculate in advance and before starting the treatment which are the concentration we want to achieve in the plasma, and we can calculate how to give the drug to get a particular concentration. And this is what is called the pharmacokinetic simulation done through a computer. So the point is that we can imagine that we have a different representation of the body according to the way a drug is administered. We can have a single compartment, so the drug is given IV, is a kind of box, the body. The drug is given as a rapid injection and instantaneously distributed, and the drug stay in the blood, and then it's eliminated. And it's what is called the first order kinetics, and we have this kind of representation. IV injection and then the elimination with time. However, we can have another representation of the behavior of the drug in the body, and this is a situation where we have a drug given orally, and we have a first phase of absorption, and this is a first order absorption where there's a proportional increase, and then we have a first order elimination. So the typical example, the representation of the profile of a drug given orally. So first we have an increase of the concentration during the absorption up to the peak. This is the time to achieve the peak concentration, which could be variable. It depends on what we have discussed before, the motility, the concomitant drugs, and so on. And then we have the elimination phase. This is the distribution phase, and this is the elimination phase. And that's on a logarithmic scale. And this is a first order elimination. In this case, the distribution is not so instantaneous as it was theoretically after the IV administration. And this is even more complicated, and this is more similar to the actual situation in humans, where we have a two-compartment models with the IV injection and then a first order elimination. So the point is that we have now three different phases. So we have the first one where we have the rapid IV injection. We have the peak, the drug is in the body, and then there's a distribution at this point in the vascular compartment, and then we have the distribution into the tissue. So we have the injection at this point, and then we have the distribution here from the vascular compartment into the tissue, and then we have a slower phase. As the plasma concentration falls below the tissue concentration, the drug goes back into the blood. So this is the classical representation. The point is that we can simulate on this model through the knowledge of the constant of distribution and elimination, and we can imagine and we can calculate which is the dose to be given, how often should be given, and which is the concentration we want to achieve. And then we can have the model which is simulated, and then we have to check into reality if the model is adequate. And that's done by sampling the blood and checking the plasma concentration achieved, and then to refine further the dose and the schedule of administration. And Marcus, do you want to comment on that? Because it's something you're really an expert on, and you're still working on that.
Just very few words. These models have been implemented broadly, but of course it's important to use this model to understand which parameters impact on the drug behavior in the body. So, for example, gender or organ dysfunction, etc. So for those covariate modeling, those models are very, very useful.
Right. So you have very complicated model where you can put all the factors which could affect the distribution, and then you are able at the end to extract the factors which are relevant and try to adapt the dose to that particular characteristics of the patient.
Right.
And one question. So the point is that clearly you cannot sample 100 patients and or with 100 blood sampling each time. So the point is that you should select which are the relevant sampling time. How could you do that? So how could you say, well, if I sample the patient at 24 hours after the administration, I get a better picture than if I sampling at 6 hours or 10 hours?
Well, you have some software that tells you what are the critical points, if you know approximately what is an IV curve you expect or a oral bioabsorption. But you can also do a good guess, for example, at the end of infusion, then towards 1 or 2 hours later, and then maybe the next days. And with the modern softwares, you can usually use quite limited sampling, because you can pool all the data from all patients, and then it's also not so critical to take samples at very precise time points.
Very good. So I think for all the new drugs, mostly for the ones which are given orally, it's important to have the knowledge of pharmacokinetics to know if we achieve the target therapeutic concentration, because it would be awful if we develop an oral drug and later on we realize that the concentration we achieved in the plasma are not adequate or perhaps are too high. And also we should know through the pharmacokinetic knowledge which is the optimal dosing interval, and not only in terms of how many times a day we should give the drug, but for example if the drug should be given 3 days out of 7 during the week, if the drug should be given weekly, and if you want to combine it, can we give the 2 drugs the same day, or should we leave some interval between the administration of the 2 drugs?
Right, and people should also understand that this is a prerequisite to submit to approval authorities for getting an approval if you develop new drugs.
Yeah. And just to conclude, I think the point is that we can develop drugs safely and dose effectively, and not to throw away compounds which could be useful if we start already with some knowledge of the pharmacokinetics in animals, because even though animals are not humans, the point is that they can give us some information on the half-life or the potential toxicity, or which could be the most potentially most active schedule of treatment. And starting from that, we can design the phase 1 and the phase 2. But without having that knowledge, it could be easier to start with the wrong dose or with the wrong schedule of treatment. And that means that we can delay the development of a very active compound for years, or perhaps we can decide to throw away a drug because we think it's not active, only because we didn't use it with the right schedule and dosing. So that, I think, just to conclude, pharmacokinetics, it's really an important aspect of the knowledge of our chemotherapeutic agents. So that's something we discussed already, the first order kinetics and the zero order kinetics, which doesn't exist in reality. And that's to conclude the area under the curve. The AUC, which very often we used because we say we can give carboplatin with the AUC of 5 when we use the Calvert formula for the adaptation of carboplatin. And actually the AUC, in my opinion, is the most relevant parameter of pharmacokinetics in terms of toxicity, because it gives an idea of the total drug exposure across time. So how long the tissues were exposed to the drugs after one administration. And the AUC is the integral in the plot of the drug concentration versus time. And we have two types of AUC. The experimental one, which depends on when the last sampling was taken. So if I decide to sample a patient up to 24 hours after the administration, my AUC will be limited to this period of time, and I cannot extrapolate further which was the behavior and how long the drugs stay. So the point is that if I have a drug with a very long half-life, I should plan already in advance to have a prolonged sampling to collect all the necessary information related to the AUC. The other possibility is to extrapolate the AUC to the infinity, so to have a very prolonged elimination. And that's depend on the characteristics of the half-life. And the AUC is important, in my opinion, for toxicity. So it's not, we cannot say we have a good AUC and the drug is effective. We can say we have a very prolonged AUC, or perhaps the kinetics is not linear. So this might be one of the reasons of the higher toxicity we observed. We are going to discuss more in detail AUC when we'll discuss carboplatin, which is the prototype of that. But it's important to remember what AUC means and which is the graph representation of AUC. So the last invitation to ask questions, and then we want to thank you together with Marcus, and now we are waiting for question or for some discussion on some points which were raised. Thank you very much. Marcus, do you have questions?
I think we discussed quite a lot. We discussed a little bit about pharmacogenetics, linear and non-linear PK. We discussed about limited PK sampling. So I think we touched about on different issues that we previously thought would be important. So I have no further questions, and there are no questions from the attendees at the moment.
Okay, so I think the point is that we are available in case there are later questions, and you can address them by mail to Marcus and myself, and we would be happy to answer to them. Also, when you have problems in clinical practice. And the other point is that let us know if it's something which was useful and whether you want to have further discussion and further presentation more related to the different classes of drugs, always keeping in mind the clinical pharmacology, so the pharmacokinetics of the different class of agents, the schedule of treatment, and the characteristics of the toxicities and how to adapt the dose and which are the parameters to look at. Well, thank you very much. And, Marcus, thank you very much for your contribution, which was very helpful.
Thanks for having me.
Thank you, Professor Sessa, and thank you, Dr. Jurga. Ladies and gentlemen, the session has now concluded. The next ESO session will take place on the 28th of February at 6:15 p.m. Central European Time. And Dr. Laura Locati, of the National Cancer Institute, IRCCS Foundation.
Тогда мы включаем микрофон. Все? Добрый вечер, я Мария Дель Гранде. Как мы поняли, что не увидели профессора наши вопросы, у вас есть какие-то вопросы по поводу лекции? Включите нам второй этаж, чтобы они задавали вопросы, если есть вопросы. Можно? Или... они же на Ютубе, они же не через этот, да. Я понимаю. Как вы увидели, тема довольно-таки сложная по поводу фармакокинетики и фармакодинамики. Я не знаю, насколько глубоко вы их знаете после университета, потому что, по идее, это мы должны были проходить фармакологию. Но вот проходить и понять — это два разных понятия. Тишина? Ну, если нет вопросов, то, конечно, мы не будем занимать больше вашего времени. И выясним к следующему разу, почему наши дискуссанты не видели, наши профессора не видели наши вопросы, которые мы очень активно задавали.
Всем спасибо.
Всего доброго.
До следующей встречи.